Great, thank you. Hi, everyone. I think our group will continue to grow as we move along. My name is Allysa Saggese, as Trista said, and I am here to discuss tonight another topic in our GAP MASLD MASH community network. So tonight's topic is comparing F3 and F4 fibrosis. We're going to be doing 2 case studies and just discussing the differences between the accurate staging and what we're using to stage people who are close in their fibrosis staging, but not quite the same. So here's my name. I'm from Cornell Medicine in New York, Manhattan, not upstate Ithaca, as I always have to clarify. If you want to record your attendance, you can use this QR code to do so now. I will wait a moment. Okay. And then we also have a magical disease state education, emphasis on the way I'm saying it. So there's a GAP MASLD MASH community network. This QR code will get you there to view the Madrigal MASH disease state education and Madrigal Rezdiffra promotional program. These are in partnership with Madrigal. They make Rezdiffra, it has to do with fatty liver, which is the topics that we are discussing. So we will get into our case studies. We have 6A and 6B. So here is our AI generated patient. Very classic kind of patient for someone with fatty liver. Now, we won't even suspect he has anything else. All of these are straightforward fatty liver. We're getting into the details of past that point of diagnosis into the details of their fibrosis stage. So he's a 55-year-old male. He's been referred for mildly abnormal transaminase levels with an abdominal sonogram that showed increased liver echogenicity, and he complains of fatigue. He has diabetes, high blood pressure, high cholesterol, sleep apnea. He does not use alcohol, so that will not come as a co-founding factor in this. You can see he has obesity, no stigmata of advanced liver disease, no hepatosplenomegaly. And he's taking some very classic meds, blood pressure med, statin, another cholesterol med, and dapagliflozin for his diabetes. So his workup labs show about what we'd expect. ALT, AST is not normal. Bilirubin's fine. His platelets are borderline. 157 is kind of close to 150, lower than 150, but it's not there. BMI is 33. INR is normal. We have a negative workup overall. We're really not worried about much. We know this is fatty liver. So here are a bunch of non-invasive tests that we have run on our patient, and this is where we get into it. So we have our FIB4, and FIB4 is basically a math problem using lab values. So in saying that, it should help you remember that anything that's being altered on labs can alter the equation and therefore the result. Just like a MELD score, if you know MELD and transplant, anything that alters the whole math equation will change the result. So we just always have to keep that in mind because sometimes there are factors that'll do that and it's not reflective of the patient. So for him, his FIB4 came up to 3.1, which is indeterminate risk, or intermediate risk, I'm sorry. There's another one here that's indeterminate. So it's intermediate. He's not necessarily cirrhotic, but he's higher than normal. We can do a fiber scan on a patient, quick in-office test that uses shear wave technology. That's what the fiber scan is doing. It's sending out a wave, seeing how stiff the liver is and sending it back to the probe. And that is a non-invasive indirect measure of liver fibrosis. And it can range anywhere from 2 to 75, which is a really large scale. We mostly focus on everything that's kind of 12 and below to determine staging. Things that are above about 12 tell us it's cirrhosis or most likely cirrhosis if it's borderline. So for him, it was 11. So we're not at 12, so we're not suspecting cirrhosis necessarily, but we are suspecting significant fibrosis. Somewhere in the 2 to 3 range, probably closer to 3. CAP score does not have to do with fibrosis, but it does define and help diagnose fatty liver. CAP has to do with fat. On the same FibroScan probe, it's sending out a little ultrasound signal, and it is counting how much of it gets back. Fat scatters that signal, and so what comes back to it, if it's much less than what it put out, then it's an inverse relationship where the CAP score is higher with the less signal that comes back because it's scattering from fat. So his CAP score is right in the middle. It's moderate steatosis, but we knew he had fatty liver and nothing else, so that's expected. The ELF blood test. So this one is not a calculation the way a FIB-4 is, and it's not a procedural object that we're going to check non-invasively. This is a blood test with a proprietary measurement of markers in the blood that can help tell and or predict a patient's amount of fibrosis. So usually it's 9.8 or above is most likely fibrosis, advanced fibrosis, risk of cirrhosis. So he's right on that cusp. Okay. So I would like to hear from everyone if I can. If anyone wants to either type or say, is there any further testing you'd like to perform on this patient? And or how would you stage this patient currently? If nobody wants to answer, I will, but I'll give it a shot. Okay. So any further testing I'd like to perform on this patient? Well, my fibrosis scores were sort of all lining up here. So I've had quite a few things that are saying about the same thing. So not necessarily. However, if I wanted to do further testing, one of the things I might decide on is an MRI elastography, which I usually describe to patients as a FibroScan, but on a bigger scale. So FibroScans have a very small probe, and they're taking basically a sample of the liver. Not really, like they're not pulling out a sample, but it's like a sampling of stiffness in one area. Whereas an MRI elastography has a whole piece that they lay on top of the entirety of the liver and do the same vibrational technology, and they can average out the whole liver instead of just a sample of it. So that is something that I could offer, but sometimes you don't need to escalate that far if you feel pretty good about multiple non-invasive tests coming together to say the same thing. So if I don't go there, the one other step beyond an MR elastography is a liver biopsy. That is considered our gold standard for diagnosing most liver diseases. And that would be pretty definitive on the staging of fibrosis. So if I had question of exactly how far along the fibrosis was, or if any of these NITs really didn't match up to each other, there would be a really good chance I would do a liver biopsy. And if a person can't tolerate MRI and I do need that answer, liver biopsy. But in this case, I think I'd feel pretty good saying he's about F3. That would be how I would stage this patient. So 2 other questions. How would I treat this patient and how would you monitor this patient? Anyone does want to throw an answer in, you can go ahead in the chat. I have the ability to see it. But at this point, he is MASH only with F3. So I would talk to him about medications, lifestyle management, and for monitoring, there is guidelines that suggest you can start doing HCC screening at F3. F4 is more of the mandatory, strongly recommended. You should be doing that. There really kind of isn't any other choice. But F3 is a softer call where you can do HCC screening and monitor your patient that way, as if they are cirrhotic. So here's the things I just said. We can start resmetirom because he has indications for it. He has fatty liver. He has F3. Resmetirom is approved and was tested on those with F2 to 3 fibrosis from fatty liver only. We did the trials here, so I knew that protocol pretty well. So I feel very confident in being able to prescribe it for a patient. However, there's plenty of reasons why people might hesitate. Patient may not be ready. Person may not, provider may not be as comfortable with it. The basis of all fatty liver treatment is lifestyle modifications. So that should always be the first and foremost and ongoing conversation with patients. So even if there's hesitancy in starting a medicine, which we'll get to the GLP-2, that can still happen with any of them, the discussion around healthy eating, being active, weight management is really important. And in those three things, I still always add managing blood sugar, managing cholesterol, managing thyroid, managing sleep apnea. There's so many more aspects to the picture that the more I pile on, so to speak, to a patient, maybe gets them to see how much it's connected and how one or two changes in stuff that they can control will help control everything else for them. So medications, you can start resmetirom because they have indication. You can consider a GLP-1. So GLP-1s are originally for diabetes management, but they have the two that are out, and then there's more coming. Just going to keep getting more and better, I'm sure. They all have one branded for diabetes and one branded for weight loss. So that's Ozempic, Wegovy, Mounjaro, Zepbound. And then some of them have gotten other indications, such as those with a history of heart disease, sleep apnea, and there may soon potentially be coming one for fatty liver. We'll see. Those have been in trials too. They do help fatty liver, and they help a lot of other things as well. So if a person has diabetes and fatty liver, a GLP-1 makes sense. If someone has sleep apnea and fatty liver, this might make sense for them too. Weight is a humongous conversation, so this comes up all the time. So it isn't an indicated reason for a GLP-1, but it is something that can be additive in the process of trying to manage weight or manage blood sugar or all the other things I mentioned. And the last thing on here is monitor for HCC, which is what I was saying, that it's a recommendation of a softer nature through the ASLD that you could do HCC screening for F3 patients. So hepatocellular carcinoma, HCC, is more likely to happen. There's a higher risk of it in those with advanced fibrosis, cirrhosis. I always describe it as, the liver has a lot of damage. That's what fibrosis is. It's scar tissue, it's damage. Just like if you keep cutting the same part on your hand, you're going to get a scar. Liver keeps getting damaged, it's going to get scarred. Just like when we can have something like skin damage from the sun, we have a risk of skin cancer. Because the liver has damage, it has a risk of cancer too. And so with F3, it's still more damage than 0, and it's almost as bad as F4. And if F4 is the one with a risk, F3 has to have some risk too. It's a little less known, but it still occurs, and that's why it could be part of the plan for a patient. I know that we do it with the providers I work with. We do HCC screening for F3s and F4. So all of this would be my treatment and management plan for our patient. Now, we're going to move on to the next one. So this is about the same person, but a couple extra things are different to make him a little bit different of a fibrosis level. So here's 6B. The moms were not very creative with their names. His medical history is about the same. He has the same kind of physical exam, same medications. No, his medical history is the same. Sorry, sleep apnea was on a second line, but it's still there. His labs are a little bit different. So his BMI is the same, AST, ALT are the same, platelets are really low. Not super duper low, but not 150, not 157 like the other ones were. And we have some higher ferritin, but the rest, we know it's not hemochromatosis. We are not compounding and confounding his diagnosis here. So same patient, but he's going to get different non-invasive testing scores. So for him, the FIB4 is a little bit higher. It's still intermediate though. His KPA on his FibroScan went way up. The last one was 11. So this one's 21. So that's pretty clearly fibrosis F4. His CAP is lower, which can happen. And I'll say that in a minute. His ELF is almost off the charts. So we are more confident. We have 2 NITs that say cirrhosis. That CAP score can be low because even though we're diagnosing fatty liver, we already had the diagnosis of fatty liver. If you think about it, if fat is throughout the liver uniformly, and it's the thing that's hurting it, and wherever it hurts the liver, the cells collapse, they break down, and fibrosis goes into that area instead. Fibrosis gets laid down to keep it all, it's like rope, it holds it all together, but it doesn't do anything. So you lose areas that are functioning cells because they're getting killed off. So we start calling this more of a burnout because the areas that have fat are burning themselves out. So what's left is areas that don't have fat and they're making up for the rest of the liver that got hurt. So it makes sense overall that his fatty number from the CAP score would be a little bit low because he might have burnt out MASH. And so while he doesn't have to have fat for us to know that it was from fatty liver, this isn't necessarily a reassuring answer. It's still concerning that the rest of the fibrosis scores are elevated. So same questions, is there any further testing you'd like to perform on this patient? And how would you stage this patient? So if there is anyone who wants to throw in an answer, go for it. I'm still looking in case there is one. But for him, that Fib4 wasn't so robust, which is okay. It may not be, but we could be sure because we probably would change our treatment a little bit with F4 versus F3, and we might want to consider MR elastography or biopsy for him. Probably would be a discussion. We'd have to see if we cared about anything else one way or the other. Do we need to check something image-wise and therefore an MRI would make sense? Do we need to know more about the etiology for sure and we need a biopsy? There might be a discussion to be had there. So this patient I might more strongly consider some sort of further testing. But if I could not obtain those things, then I got my fiber scans pretty high. Alpha's pretty good, pretty high, pretty sure there. Fib4 is still a math equation, so perhaps there's just the things altering its outcome to not put it over the 3.25, but it's pretty close to it anyway. So how would I treat this patient and how would I monitor this patient? So it's almost the same as the other person. This one, though, he would not be eligible for resmetirom because it's not approved for F4. So you should not be giving it to anyone with cirrhosis. Although it is only on the label that you should not, it's advised against giving it to decompensated cirrhosis. Perhaps at some point it will be able to be given to cirrhosis, but not yet. We don't know. But right now it's not indicated for it and therefore should not be given. Monitor for HCC is a must. This person is cirrhotic and they are at high risk of hepatocellular carcinoma. Diet and lifestyle, always for everyone, all fatty liver, and honestly, just all liver patients, and honestly, just all patients. Everyone in the world should be following a good diet and lifestyle. Because he's cirrhotic, we should screen for esophageal varices. So there is Baveno criteria, which I don't quite get into here, but that is something that uses FibroScan scores and these non-invasive testing. I think it is really specifically FibroScan, though, if I remember correctly. And if the number is over 20, then there's a really high chance of esophageal varices, and we should screen for them. Anyone below 20/15, it may or may not be present. They may not have that portal hypertension to be causing them. So that it all ends up becoming, a discussion with the patient and a decision on the provider's part. But that would be the safest thing, is to have at least one endoscopy, and then if you find varices, they can be on a beta blocker. GLP-1 is not listed here. I will say, though, that GLP-1 is safe in cirrhosis, but I would take that more into consideration of, all of the other potential comorbidities and how maybe fragile their cirrhotic state is to see how much they can handle. Cirrhosis can cause, if it's pretty damaged, like really cirrhotic, really scarred up in there, can cause a lot of muscle loss. So can GLP-1. So you really wouldn't want to give it to someone who's maybe starting out a bit sarcopenic, because you're just going to accelerate that. But that's part of the judgment calls as to what will work best for the patient. So here's a nice comparison of the things that we were looking at. Their FIB4s were the same, but the ELF and the FibroScans were the differences between the two patients. So it highlights to me how FIB4 may not be the end-all be-all best thing, but it is a start. It's some sort of idea. So we have encouraged groups like endocrinology and primary care to just do a FIB4 in their patients. They're probably collecting all the right labs anyway. It has to do with platelets. I think you just need a complete metabolic panel and a CBC to get a FIB-4 score, because it's also based on age and I think gender. I can't remember that by heart, sorry. No math wizard with that one. But if a provider's drawing the labs that are included in a FIB-4, it is not hard to just make the system calculate a FIB-4 for you, and at least you'll have some idea, a little bit of a potential risk for the patient and get them seeing the right kind of provider. So that is usually our guidance, is if the FIB-4 is over the 2.45 scale, then they should see hepatology or at least get a FibroScan and start there. But these ELF scores are a bit more specific with their markers. They're like a patented, I think is the way to say it, marker in the blood that have been more related to and more diagnosable for fibrosis. And transient elastography is actually just tapping at the liver, seeing how stiff it is, knocking on its door and saying what's up in there. So it's an even closer approximation of fibrosis by doing that. So that's how I start to interpret these tests and how much to trust them and what to do with them when I see the results, especially if they're a little discordant from each other, as these can be. So some of these things I think I've already gone over. How do these two patients compare in management? Not too different, but I would say cirrhosis means you're more thinking about portal hypertension, decompensation, like how close are they to worse outcomes, and maybe the urgency is a little bit higher. F3, though, I would say is probably a high urgency as well. You're like, well, you're on the cusp of cirrhosis. Let's really back in if we can. So the management is very, very, very similar. I think it is also up to what kind of resources a place has as to what you can and can't do. If ultrasounds are so hard to get for someone for HCC screening, it might change how often you're asking your F3s to do things like that. So that part would be more nuanced and perhaps not as applicable as, we can see in New York. So we have a lot of resources, but that does come into play for some providers. So staging between F3 and F4, the non-invasive test that I most typically use probably ends up being FibroScan. It is very accessible in my office. It is quick. I know how to do it. I can just do it myself, and that makes things faster. But like I said, a FIB-4 for a provider that may not be accessing a FibroScan or an MRE, that's a math equation that they aren't doing, and so that helps, and that would be a good place to start, and that's usually what we encourage. When NITs don't have the same answer, I think of it as an escalation, and I think I might have already said it in the way I escalate. There's the FIB-4, ELF's a pretty good one. FibroScan, maybe ELF and FibroScan are around the same if you can have one or the other. MRE elastography, liver biopsy. So liver biopsy would put the end to all the questions, but all of these would be the non-invasive testing up to that point. And when is HCC surveillance important? In these people all the time, but it is important in anyone with advanced fibrosis or cirrhosis. And there's really just kind of no ifs, ands, or buts about that. I would say it's important all the time to all the patients, but these are the ones who are at risk and therefore should be counseled about it and made to understand why we're asking it of them so they get it done too. So this is actually the end. We have a couple minutes left. I will stop sharing my screen. And great. Thanks everyone for listening.